So, case is 49-year-old male coming in with chest pain. He has a history of hypertension. Came in 45 minutes. Pain started 45 minutes prior to arrival. He has no cardiac history, except that his father had a MI in his 40s. He said that the chest pain feels like a kidney stone in his chest. When the pain came on, he said he was diaphoretic, and he was also complaining of left arm pain and pain in his neck. On physical exam, he was stable. Blood pressure was in the 140s, normal heart rate, oxygen saturation in the high 90s. At this time, he said the pain wasn't as bad as when it first came on, and actually he was in the bed making jokes about his pain, everything that was going on. But he looked very uncomfortable. So, this is our first EKG. Give you guys a second to take a look. See this EKG, given his story, gave him some aspirin, gave him some nitro. Nitro helped with the pain. About 30 minutes later, he said the pain came back, so we got a repeat EKG. This was his repeat EKG. So, we saw this repeat EKG, called cardiology to activate the cath lab, started him on some heparin, and then transferred him to a facility that could do some PCI. So, Dr. Musa, if you want to explain what you see in this first EKG.
First thing I'd like to point out is very astute and proper to get a second EKG. That should always be lesson number one. Never hesitate to obtain a second EKG in this setting, in this presentation, even if you don't see very much on the first one. There are a few subtle findings on this first EKG, and of course, obviously, you'll start seeing a PVC in leads 2 and in leads 3, which you could expect in the setting of chest pain. And then if you take a look also at leads V1 and V2, you'll see a T-wave inversion in each of those. And you know, in the setting of chest pain, it might make you think of a pulmonary embolism. I think everybody in their gut knows that something's going on with this patient. And then if you look a little closer, you'll see a T-wave inversion in aVL. This oftentimes is a very early sign before an impending acute MI. This is oftentimes discussed by Dr. Amol Mattu in many of his teaching lectures. And when you notice this, this should really alert you to a possible MI developing. And as you can see in the second EKG, Dr. Hoda and his team did pick up on this myocardial infarction and proceeded with transferring this patient to get PCI. Again, you'll see that there's ST elevation in leads 2, 3, and AVF, and and ST segment depressions in V1 and V2. Oftentimes, this acute MI could commonly involve the inferior wall and the right coronary artery, as well as the mid-left anterior descending artery.
So this guy went to the cath lab, and we have some pictures for you from the angiogram. So this guy had a 99% occlusion of his mid-RCA. So there's the occlusion right there.
Wow.
Yeah, so pretty dramatic change after they stented him. Right there, you can see it's pretty patent now. And then this is a EKG at post-PCI. So the important things to note here is that T-wave inversion in aVL can mean early MI. It can be occlusion of the RCA and even mid-LAD or circumflex.